first topic will be by single step trans PRK by Dr. Miriam Joseph. She is from Area Eye Hospital, Tichur. Okay, over to you.
Thank you, sir. So the first topic for discussion today is single step trans PRK. So let's look into a brief history of laser refractive procedures. As we all know, PRK or photorefractive keratectomy was the first laser refractive procedure performed. Which got an FDA approval in 1995. It was performed by Dr. Margaret MacDonald in human eyes. But the procedure of trans PRK, which involved the use of alcohol to loosen the epithelium with manual removal of epithelium, followed by the stromal refractive ablation, was a bit cumbersome. So when LASIK came into play, everybody was more in favor of LASIK. But everybody knew the advantages of PRK over LASIK, because there is no cutting of tissue in trans PRK with good, better biomechanical stability of the cornea. So the concept of transepithelial PRK was first described in 1999. So what is transepithelial PRK? It is a procedure where the epithelium and the stroma is both ablated with laser. But it did not get wide acceptance because there was no uniform method for the epithelial ablation of cornea. So 20 years after the inception of the idea of transepithelial PRK, in 2009, a new approach called single step transepithelial PRK was brought about by the Schwind Amaris laser platform in 2009. So what is the basic difference in all these procedures? Let's see in brief. So PRK, as we all know, we loosen the epithelium with 20% alcohol, scrape off the epithelium manually, and then we do the refractive stromal ablation. And then we put bandage contact lens and the patient will recover. So what is the difference in transepithelial PRK? So we do laser ablation of both epithelium and the stroma. So we don't need to use alcohol and the procedure becomes less cumbersome. And the difference in single step transepithelial PRK I will show in a few slides. So as I said, there was no uniform platform for epithelial correction in the transepithelial PRK earlier on, because in the earlier machines they used to do flat PTK, that is phototherapeutic keratectomy for the epithelial ablation. So for this we need to consider the epithelial thickness. We all know that the epithelium is not uniformly thick. It is thinnest at the center of cornea, that is about 55 microns normally, with gradually increasing to 65 microns at 8 mm of cornea. As we all know, the refractive procedures are performed in the central 8 mm of the cornea. So if we don't fully ablate the epithelium, or if there is over ablation of the epithelium, it will affect the refractive power correction. So in the flat PTK mode, which used to be done in the earlier machines, 65 micron of the epithelium used to be ablated in the central 8 mm of cornea. So what will happen, because the thickness is only 55 microns in the center, there is extra 10 micron ablation of stroma in the center, which will induce a plus hyperopic correction. So Schwind has brought about a modification in that it does radial PTK mode, which takes into consideration this gradation of epithelial thickness. So when a patient comes for a refractive procedure, we do anterior ASOCT for these patients and find out the epithelial thickness for them. And then individually we can customize the epithelial ablation for these patients by entering the central epithelial thickness and the peripheral epithelial thickness. So the laser machine will modify or customize the ablation of the epithelium according to each patient's epithelial thickness profile. So how is that possible? So Schwind has a technology called Smart Pulse technology. Here they will they make a 3D Fullerene model of the cornea, which gives a precise depiction of the anatomy of cornea, and this gives the precise epithelial ablation with the central and peripheral, taking into consideration the central and peripheral difference of epithelial thickness. And also there is the corneal stroma, which is residual, is much more smoother in this new technology of smart pulse technology. This is a scanning electron microscope picture. The right side shows a residual stroma, which is very smooth. This is done with the smart pulse technology as compared to the older machines, where you can clearly see the difference, that there is difference in the smoothness of the residual stromal bed. So what is the importance of this smooth residual stromal bed? We get faster and more regular epithelial healing over the residual stroma, which gives a better postoperative vision and quality of vision. So in summary, the procedure, it happens like, first there is laser refractive stromal ablation that happens in this procedure, which is immediately followed by epithelial ablation. So what is the difference in the earlier forms? As I already said, in the earlier machines, the first ablation is of the epithelium of around 8 mm. Then you have to manually switch the laser to a PRK mode, where the stromal ablation or the refractive ablation happens. So there is a time delay between the epithelial ablation and the stromal ablation. So in this single step transepithelial PRK that has been newly introduced, what happens is that first the stromal ablation, then automatically the laser machine will switch to the radial PTK mode, which will ablate the epithelium also, and this epithelial ablation will correspond to whatever is the optical zone. So if you are ablating a 5.5 mm of optical zone, the epithelial ablation also will be 5.5 instead of the 8 mm. So we have a smaller wound, which will result in faster epithelial healing and better patient comfort post-op. So this is a single step procedure where epithelium and stroma is ablated together. So the indications of trans-PRK, the range of correction we can give is myopia up to -10 diopters, hyperopia up to +6 diopters, and astigmatism up to 5 diopters. We can also give presbyopia correction with this machine. We will consider PRK if for very low powers like -1 diopters of myopia and hyperopia of less than +0.5. So just to highlight a few advantages of the single step transepithelial PRK. As I already said, there is simultaneous ablation of the epithelium and stroma. So this will reduce the overall treatment time. So what is the advantage of that? We can reduce the treatment time, and there is less chance of stromal dehydration, which can happen between the two steps of epithelial and stromal ablation. So there is more effective power correction which we can achieve with this procedure. And the epithelial ablation corresponds or overlies the stromal ablation profile. So only the minimum amount of epithelium needs to be ablated in this procedure, which gives us a faster post-op wound healing and better patient comfort. This is a bladeless, touchless procedure, so there is very less instrumentation and there is very less chance of infection with this procedure. And since there is no cutting or making of flap, it is suitable for patients who are involved in contact sports, defense personnel like army, police, firefighters, and there is no rise in IOP during the procedure, unlike in LASIK or SMILE procedures. Hence, it is suitable for glaucoma or glaucoma suspect patients. And even in retinal hole patients, it is safer to do this procedure as compared to LASIK or SMILE. Now a few words about higher order abrasions. As we all know, cornea is not a very smooth structure. It has lot of small peaks and bumps and valleys, and these result in something called as higher order abrasions. The most common of which are coma, trefoil and spherical abrasions. And these higher order abrasions are responsible for symptoms of glare, ghosting, shading, and especially difficulty in night driving. So whenever a patient comes to us for a refractive procedure, what we do pre-op is we take the corneal topography, and then in the corneal topography itself, there is an option for wavefront analysis of the cornea. So the wavefront analysis is done, and then we can know whether the patient has a higher order aberration above a certain limit. We may put the limit as more than 0.5. If they have significant higher order aberration. That is also going to be affecting the quality of the vision that they are having. So we need to correct that also. So the advantage that we have is that we can incorporate corneal wavefront guided transepithelial treatment in these patients who have higher order aberration. So the post-op problems of glare and difficulty in night driving can be addressed with the same procedure. Also, normally also without the corneal wavefront guided treatment itself, it's an aberration-free treatment. That is, we introduce very little aberrations in the cornea. This happens because of the smart pulse technology that we have, which leaves a very smooth residual stromal bed. Another advantage the trans-PRK has is in thin, irregular corneas. As we all know, all other laser procedures are contraindicated in these conditions, like keratoconus suspect, or in ectasias like keratoconus, or post-LASIK ectasia, post-keratoplasty eyes, where severe corneal pathologies are there, severe corneal irregularities, post-RK patients, retreatments where there are decentrations. In all these cases, all other laser procedures are difficult or contraindicated. So this is the go-to procedure in these type of corneas. So what do we do in keratoconus? So in keratoconus, as we all know, there is progressive thinning with coning of the cornea. So this coning will induce highly irregular astigmatism and myopia, and also a high degree of higher order aberrations, which give a very poor quality of vision to these patients. So what do we do for them? What can we do for them? We can correct the higher order aberrations with this corneal wavefront guided therapy, and also the main aim is to regularize the cornea. That is, we can flatten the steep areas and steepen the flat area so that we can get a more regular corneal surface. In keratoconus, the main treatment depends, or we decide what treatment we can give for them depending on the corneal thickness, and secondly the amount of higher order aberrations that they have. So if a patient comes to us and we do corneal topography, if the thickness we find it is more than 500 microns, we can actually give them a full correction of their power with in combination with always C3R, collagen cross-linking. All keratoconus patients, whatever we do, we have to combine it with collagen cross-linking to give the cornea more strength post-op. So in more than 500, we can give full treatment of the refractive errors. If the patient has a corneal thickness of 450 to 500, we follow something called an AEGIS protocol. So here we do corneal wavefront guided trans-PRK with collagen cross-linking. So the main problem in these patients is higher order aberrations, right? So we give them full treatment for these higher order aberrations which are visually significant, and also then we correct a part of their sphere and cylinder. That is, we need to keep the stromal ablation to a maximum of 55 microns so as not to ablate an already weakened cornea. So a total of 55 microns of stroma with 55 microns of epithelium is what we do for these patients. So first full correction of higher order ablation, and whatever stromal ablation is left, we can give the remaining sphere and cylindrical correction. So what we offer to these patients is a better acceptability of spectacles or contact lens. We cannot offer them full correction of their refractive errors, but we can give them a better uncorrected and corrected vision, and also better quality of vision and better tolerance to spectacles. So imagine if the patient is between 400 and 450 microns, a treatment that we follow is TREC, topo guided removal of epithelium for keratoconus, and this is also combined with C3R. Here what we do is that we identify the cone. Here in this topography, you can identify that this is the cone, and this is a treatment plan for TREC. Here you ablate over the cone, that is the whole of the epithelium over the cone with 20 microns of stroma is ablated. This is just to give them a better regularized cornea so that they can have a better quality of vision. So a few cases that we did in our center. Case 1 is of a 20-year-old male who was a recently detected keratoconus patient. His uncorrected vision was 624 and 69 parts in right and left eyes with a thickness of 467 and 470 respectively. This is the pre-op topography which shows where you can clearly see the cornea of right and left eyes. So we did corneal wavefront guided trans-PRK in combination with C3R in December of 2023. So post-operatively, he gained an uncorrected vision of 6'9" and 6'6" parts from 624 to 6'9" parts. And his best corrected vision was 6'6" parts and 6'6", and the correction that we had to give post-op was very minimal compared to his pre-op, that is minus 0.75 sphere with minus 0.1 cylinder at 110 in the right eye and only minus 0.5 sil in the left eye. And you can see that the K max has reduced from 54 to 49 in the right eye and from 52 to 48 in the left eye. And the thickness is also maintained at like around 430, 435. So this is a comparative topography of the right eye. Here you can see that the intense red of the topographical cone has reduced to an orange, which shows us that the keratometry values have come down. And in the left eye also, the same result we got. And this is just a picture of the wavefront analysis, the right eye and the left eye. So this is the wavefront analysis of the right eye pre-op. In post-op, you can see that the wavefront is much better, and you can get the value also like 1.43 has improved to 1.72, which is very significant for this patient. And the left eye also, the higher order aberrations has reduced from 1.17 to 0.53. This really improves their quality of vision. So in other cases of a 31-year-old known case of keratoconus, she's a female teacher. She was not at all comfortable with contact lenses. Her uncorrected vision was 636 and 624. The same treatment was done for her, and her post-op uncorrected vision became 612 in both eyes. She was amblyopic in her right eye, so her best corrected vision was 612 in her right eye and 6'6" parts in her left eye. And compared to the pre-op refraction, we can see that the post-op refraction that we had to give her was really reasonable. And the K max reduced from 52 to 47 in her right eye and from 51 to 49 in her left eye. So the pre-op and post-op topography of the right eye and left eye, which shows that there is actually better cone configuration. And the higher order aberrations have also reduced from 1.5 to 1.15 in her right eye and from 1.94 to 1.15 in her left eye. So this now last case is that of a 33-year-old keratoconus patient. She was using soft contact lenses for the past 12 years. Her uncorrected vision is 6/60 in both eye. I don't have a post-op topography for her, but the post-op refraction shows that from 660 she has improved to 624 and 69 uncorrected, and corrected she has improved to 612 and 6 parts. And the post-op refraction from -6 it has improved to -1, and from -5.5 to 3 sil. So the overall the patient quality of vision and her tolerability for spectacles has increased a lot post-procedure. So some advantages that I want to highlight with this procedure in keratoconus is that because we are able to correct the higher order aberrations, and this is induced by
Dr. Miriam, I think we are slightly exceeding the time.
Okay. I'll just give some points. So keratoconus, we can give them a better quality of vision as mentioned. So in treatments also, this corneal wavefront guided treatment is a big help because we can customize the treatment. And another thing is we can give them presbyopic correction, that is with presbymax, where we make the cornea multifocal by giving a near vision correction at the center and a peripheral distance vision correction. So the important thing to note in that is this, the patient should be more than 45 years of age for this to be eligible with a normal pupil and less of higher order aberrations. An advantage for this is that we can do this in pseudophakic eyes where where they have been using monofocal IOLs, where they want to have a multifocal enhancement. The one disadvantage of this is that we cannot use multifocal IOLs later on in their life. We need to reverse the multifocality of the cornea before that. Just one case of a presbymax that we performed. The patient 4 months post-op had 6/6 binoculars, N6 and intermediate N6. So just to mention of the complications of this procedure, post-operative haze was the very dreaded complication that we always used to face with PRK. In trans PRK, haze is visually very negligible. Maximum grade 1 is what we have seen, and which is usually self-resolving in 6 months. So just a comparison, the treatment time for this procedure is around 5 minutes for each eye, and as I already said, all the laser procedures contraindicated can be done with this. So the take-home message is just the last slide. It's a no-touch, bladeless, single-step procedure which results in faster healing, less of dry eyes, enhanced corneal biomechanical strength, no flap or incision. So the go-to procedure in all the other contraindicated cases like keratoconus and thin irregular cornea. So this is the go-to procedure in all these cases. Thank you.